I see a few folks are still joining, so I'll just give them another second or two. Well, welcome everyone. We are excited to have you here this afternoon. We've had an excellent response to this webinar, a great turnout, so we are excited and welcome. I know that you're all just as eager as we are to learn about Connecticut's Stay Connected program. With us today is Nicholson, who is a professor at Quinnipiac University with an appointment in the School of Nursing. The overall goal of his program of research is to improve quality of care of those suffering from social isolation through targeted measurement and intervention. Patricia Richardson is the statewide ADRC coordinator for the State Unit on Aging within the Department of Aging and Disability Services. She oversees several Administration for Community Living No Wrong Door grants, the Veterans Directed Care Program, and MIPPA ADRC grants for Connecticut. Arlene Lugo is a resident certified assistive technology professional and the program director of Connecticut's Assistive Technology Act program, as well as assistive technology consultant for the State Vocational Rehabilitation Agency, overseeing a variety of initiatives to help increase access to AT for individuals with disabilities of all ages at work, school, and in the community. Before we begin, I'd like to do a few reminders. To see captions, click the CC button on the control panel. You may enter your questions and comments in the chat window. We are going to be holding questions until the end of the presentation. However, if you need to have something clarified, please let us know in the chat window and we will be sure to get that clarified for you. Otherwise, we'll be holding the questions until the end. And as always, please be sure to check out atcenter.net for upcoming events. Event registrations are sent via link to our AT3 listserv. For today's webinar, please be sure to look for a post-webinar email that should be in your inbox tomorrow with the survey link. We encourage you to complete the survey and, as always, provide suggestions for future webinars. And with that, if you give me 1 second, I'm going to stop sharing this screen and turn the screen and the mic over to Arlene. 1 moment, please. Take it away, Arlene.
All right, thanks so much, Kim. Thanks, everybody. We are so excited to be here today to talk to you about our Stay Connected program in Connecticut. As Kim said, I'm Arlene Lugo, Program Director for the Connecticut Tech Act Project. I know many of you on the call, or some of you on the call, and I'm very happy to be here. And I'm here with my colleague, Patty Richardson, who's from the State Unit on Aging, and both of us work for the Department of Aging and Disability Services, or ADS. And we are happy to be joined by Professor Nicholson from Quinnipiac University, who's done extensive research on social isolation and aging adults. So I hope that you find the presentation informative today. And to get things started, I'm going to turn it over to Patty, and you'll be hearing from all of us. And I hope that you find this informative and enjoyable. So thank you. Patty, next slide.
So in April 7th of this year, the Administration for Community Living announced funding for No Wrong Door systems. And the purpose was to offer emergency funds to support capacity and research allocation at the state and local level for coordination across agencies and to also support immediate response to urgent needs. Funds would enable states to support ADRCs in providing critical access to those at risk of adverse effects resulting from our national pandemic, such as social isolation, limited access to nutritional supports, and personal care services. And ADRCs were tasked to enhance and increase virtual access to services, such as utilizing telehealth technology to engage with healthcare practitioners and case managers. The funding to Connecticut was based on the demographics of people that were 60 years of age or older and the number of people with disabilities. And we in Connecticut were allocated $455,454 to do this work. The grant period is started in April 1st, and it will be extending to September 30th, 2021. Next slide.
So in Connecticut, we decided to name our program the Stay Connected program as a way for us to focus on the positives of staying connected or being connected with others, instead of focusing on the words of social isolation, which can offer a more negative connotation. We also didn't want individuals who were calling in to be screened to be led into answering questions in a way that they would be sure they were seen as socially isolated. So we wanted to focus on social engagement and connectedness. The objective of our program is to connect individuals with disabilities aged 18 or older, or adults 60 years of age or older, to the most appropriate assistive technology to help foster improved engagement and connection with their family, friends, their community, and medical providers during this pandemic when many of us are staying home to stay safe. Next slide, please. In order to lay the foundation for this program, Patty and I, as the state leads, agreed that it would be best to tap into the 5 area agencies on aging that we have here in Connecticut and the 5 centers for independent living, who all of them already receive calls from individuals in the groups that we're trying to tap into and reach through their information and referral phone calls. Our thought was if we could build in the screening for our Stay Connected program right into their information and referral calls, then they could identify individuals who would meet our criteria and refer them right over to our program using the screening tool that we devised. So we contracted with all 10 of those agencies, as well as 3 of the assistive technology partners for the Tech Act project, who already provide AT Act services such as AT device demonstrations, AT device lending, trainings, public awareness, and more. These 3 agencies, UCP of Eastern Connecticut, EastCon, and the New England Assistive Technology Center, were selected because of their background in providing AT evaluations and trainings to individuals from our vocational rehabilitation program, which I also oversee. And they also have background in aging in place. So lastly, once we got the contracts taken care of, Patty looked for the best tool to help us screen individuals into the program. And she came across Professor Nicholson's 6-question social isolation scale. And he has been extremely willing to work with us. And it's a bonus that he's right here in Connecticut at Quinnipiac University. And Professor Nicholson has been providing us with guidance on the scale and our overall process, helping us to make adjustments as necessary and offering his research students to help us conduct follow-up surveys. So we're going to be talking more in depth about our screening tool, the social isolation scale, and the post surveys. So first, let me give it back to Patty, and she'll talk about our overall process.
Next. So due to the fast pace of calls that usually come into the area agencies on aging and centers for independent living, we wanted an easy way for those staff doing these INR calls to screen for socialization, to identify those most in need, to track the impact of the social isolation, and then also to minimize the reporting that those agencies might have to do since they were already reporting for other programs they were administering. So we created an online Survey Monkey link that was available to the staff as a favorite bookmark for easy access to staff, where we could incorporate the 6 questions that we were going to be asking callers. And then we were using a unique identifier so that no information about specific individuals would be identified within the Survey Monkey. So what we did was we had one person per agency as a point person who would be responsible for tracking the identifier with the beneficiary information. We set up the Survey Monkey so that the end of the survey responses, it it automatically provides the outcome of the scoring, so the staff would automatically know whether individuals met our criteria for the Stay Connected program. And if they did, in fact, individuals met that criteria, they would then explain that we had a special project called Stay Connected that would help them identify technology that would help them maintain access to their community and doctors during the pandemic. We also asked additional questions to determine their current access and success in using the technology they may or may not have and the internet they may or may not have, and what programs they might be connected with as a way of seeing whether or not there was other funding streams that we might be able to connect them to. If they met our criteria, a referral is then sent to the assigned Tech Act partner that is in their area. And then Arlene and I, who have access to the SurveyMonkey, would download the SurveyMonkey results so they didn't have to repeat that information, and it was sent with referral to the Tech Act partner. And then the Tech Act partner would take that referral, and then they would reach out to the individual and establish a remote consultation, either by phone or remotely, oftentimes with the help of assistance with other people identified by the AAA or the SIL agency. Based on the consultation, a recommendation would be made with the individual, and then a brief follow-up written report is forwarded both to Arlene, myself, and also to the referral source of the Area Agency on Aging and Center for Independent Living, because some of those agencies had some funding available to them, or they would help with trying to access funding for the actual cost of the technology. And once the technology is purchased, then the Tech Act partner provides training and support on the use of the equipment. Next slide, please. We discovered very early on that there was a funding available to purchase AT equipment, but there were actually fewer resources for internet connection, consultation, and the actual training on use of the technology, which we thought was so important. To maximize these CARES Act grant dollars and to ensure individuals had access to the consult training and support, we ended up reaching out to our state agencies and partners to see how we could streamline access to these funding streams and how we could streamline referrals back and forth and to explain our project. And we met with the state Medicaid waiver units, which includes Money Follows the Person and our Community First Choice, which are under a certain, they have different state leads. And we also met with a state lead for the National Family Caregiver Respite Program supplemental funds that also received additional CARE Act funds that could be accessed for technology. And then we also reached out, we're fortunate in our state, we have a Plan of Connecticut Charitable Trust Foundation that provides grants to people with disabilities for things such as equipment and supplies to increase independence. So we reached out to them, explained it, let them know that we would be sending referrals, and tried to make sure that there would be a streamlined process to getting communication back and forth. In addition to that, we surveyed the senior centers in our state, resident service coordinators that are embedded within senior disabled housing, and all municipalities in Connecticut to gauge where Wi-Fi was located or internet, where there might be computer training we could tap into, and then any agencies that were providing loan programs for technology, such as we found in some libraries and senior centers. Next slide, please. And as Arlene mentioned early on, we discovered we really needed some way of gauging social isolation for individuals and to objectively screen for social isolation so we could make sure that we were allocating funds most appropriately to the people most in need. And we contacted Professor Nicholson at Quinnipiac University, who ended up having to be one of our guest speakers at an older adult behavioral health conference that I was in a planning committee for, that ended up getting canceled due to the pandemic. It happened right when everything hit. We were very pleased when we reached out to Professor Nicholson that he not only provided us with valuable guidance, but agreed to allow us to use his validated social isolation scale for this project. And it's my privilege to introduce Professor Nicholson, so he can talk more about the social isolation scale to you.
All right, thanks, Patty, and thanks everyone for being here and being a part of this really important conversation. I think that just right off the bat, it's really important for me to just talk ever so briefly about the importance of understanding what we're all talking about and what we're all measuring. I think there's a fair level of what I would call conceptual ambiguity related to what we're actually trying to measure. So when I'm looking at the concept of social isolation specifically, I'm actually looking at it in a very conceptual way. So I began looking at social isolation fairly long time ago. When I think about it, it's 2005. So when we are in times where just yesterday feels like forever, 2005 is an eternity. So I've been reviewing isolation and looking at it from multiple angles since then. I've been doing conceptual work, theoretical work, and measurement work related to that concept and other very closely related other concepts. Because when you get into the literature, there are a fair number of concepts that are similar but different, and it's important to distinguish between those concepts. So I think that it's really important to cover a definition of social isolation, because that is the framework for measurement. Because if we don't know, if we can't define it, then how are we going to be measuring it? So for me, looking at the definition of social isolation is so crucial. And the way that I came up with the definition that I used to later construct the instrument is by conducting an evolutionary concept analysis. And that provided me with the definition that I use of social isolation. And that definition is the distancing of an individual psychologically or physically or both from his or her network of desired or needed relationships with other people. So in other words, the number of people or the connectedness that you have and how you feel that you attach or connect with other people, belongingness, are the two main components of that definition. So that's relevant because we need a measure that's going to actually operationalize that definition. And the thing about definitions is that some of them change over time. You know, nothing is stagnant. So as the literature dictates what is changing over time, you know, we need to be up on what the most current definition is. We can't be using things from yesterday because, as we know in this field where we're working with, individuals, healthcare, nursing for myself, things change minute to minute, and we need to be up on that. So for me, when I'm looking at the social isolation scale, I'm seeing two distinct areas, and you can see from the slide here that there is a top part and a bottom part. Questions 1 through 3, and then 4, 5, and 6. So there is a subjective area that looks at belongingness, and then there's an objective area that looks at connectedness. And the initial setup of these questions was put together based on the 5 attributes of social isolation, which were found through extensive literature review. And those 5 areas were number of contacts, so that's the connectedness, the feeling of belonging, fulfilling relationships, engagement with others, and the quality of social network members. So this was all, again, discovered during the conceptual work and the concept analyses that I was doing on social isolation. So it's important that the instrument itself measures the concept that you want. So in this case, social isolation. And it needs to be operationalized based on that definition. That's something that's, very, very important to people in the field, and certainly to me as far as making sure that what we're measuring is actually being clearly defined. So as I mentioned, definitions do change, they drift, they evolve, whatever you want to call it. But by taking that conceptual work and doing the hard work of figuring out how others are defining it, how others are using the concept, what are surrogate concepts, what are similar concepts, all that is rolled into, well, it started as this. You know, this first notion of social networks in the 1950s, and then later evolved in the 1970s into more specifics to social networking, and then from there it's really kind of taken off, and there's been so much lately given all that's going on in the world, and it's an exciting time on one side, and it's also kind of a frightening time and sort of the other side. But I tend to be an optimistic person, so I think this all moves things forward quite nicely. So the social isolation scale itself is something that measures social isolation, not social networks, not social support, not social integration, not any of the other socials, not loneliness. It's specific to social isolation, and that's relevant because I see far too often that folks that are trying to measure social isolation are using a social support instrument, and that just doesn't match up with the definition. So that's why we need to be careful about the science and the measurements that we're using. So an important distinction between a psychometrically validated instrument and an index, which the social isolation scale is a psychometrically validated instrument, is that an index is essentially a measure that sums scores from a bunch of different questions. And one of the most popular ways to measure in this area of the literature, which was created in the late 70s, is in fact an index. And an index is great at looking at things like risk and probability and mortality rates of various things. However, it is looking at social networks, and that is the objective side of social isolation based on the concepts that I had looked at. So, so what does this really mean? It means that you know, no matter what you do or what's done, the instrument is really what's helping you to figure out the determinants and distribution of the condition, and the accuracy of that is really, really important. So if we're using an index that's not sensitive to change, meaning what it's looking at, these are what we call traits. They're things that are unchangeable. So one of the main indexes that was very popular that I had mentioned was looking at things that were unchangeable. Marital status. It was looking at religious and spiritual involvement. So those are things that are essentially built-in traits for people. They're very difficult to change. So it's not the instrument, the index, there's a difference between them, and we need something that can pick up changes. So as programs are moving forward and we're connecting people with resources and allocations, it's crucially important that we are able to pick up the good work that people are doing. Because if we're waiting for people to have a change in religion or spirituality or a change in marital status, that there's almost nothing that we can do to really impact people. And I happen to believe that social isolation is a construct that is a state. It's something where people get into over time, and it's something that we can pull them out of as well. And technology and resources are one way to really do that effectively. So the social isolation scale is validated. It was validated. I worked with the AARP Foundation and the AARP Foundation Tax Aid to administer a questionnaire to older adults. And that questionnaire was, you know, provided a tremendous amount of data that I was able to use for the psychometric testing of the scale. So it's been validated for use with older adults, but thanks to this great collaboration, you know, with Patty and Arlene and a lot of other great folks, there's a really nice opportunity to build additional data. And not only does that additional data help to refine the precision of an instrument, because we always need to be doing that kind of work, but it also provides an opportunity to investigate other populations that are relevant. So I do the majority of my work with older adults. However, I do recognize there's a lot of other populations in need. And one in particular is the 18+ population. And the 18 plus population with disabilities, a variety of disabilities, those folks, you know, having disabilities can be, it can basically be something that's very, very isolating. So it's hugely important to be able to accurately, excuse me, assess for this in that population. I think that's something that is really exciting, and it's we're looking forward to taking more in-depth look at that type of measurement. Also, looking at individuals as far as social isolation goes, prioritizing them for services and allocation. This is really a new and exciting and really unique way of using the social isolation scale. So when I heard about the work that Patty and Arlene are doing, their idea of using this validated measure to identify people and prioritize them and get them the resources that are tailored to them based on their score, it's just a really great way and a really it's a really practical way to use the instrument. And as somebody who is a professor and a faculty member in the academic world, having someone pick up your work and use it in real life, there's nothing better, because at the end of the day, we're trying to put together things and write papers for people to use. So when people are able to pick up that work and use it to help patients and to help clients and to help individuals, that's really what it's all about, you know, on my end anyway. So when we first started, like I said, you know, in instrumentation, we're always looking at how the data impacts what we know and what we don't know. So very, very early on in this project, we had a small sample, and we got together and we looked at that small sample and we assessed it based on what we were seeing and compared it to the original data set that I used to set the cut scores. So in fact, my original cut scores were tertiles. So I had 3 levels of isolation. And based on what I was seeing in the sample data here, it led me to go back to my original data and really look at some of the anchors that I was using and how I was putting together my cut scores. So I sort of revised, because it was the right thing to do, into quartiles. And this made the scoring clear. It made the things more precise. It better identified people impacted by isolation. So again, it was an overall win for me and the work that I'm doing, but also being able to identify people who are isolated in this project. So in general, you know, for social isolation, we would be expecting between 10% and 50% to be isolated. So just take a minute to think about that. Anywhere up to 50%, so half of older adults we're expecting to be isolated. That's a huge amount of people. And it's, you know, and that's, you know, we have to take into account all of the other things that are going on in the world today too. So if you look at that as an average of about 24%, which is a separate paper that looks at prevalence, a quarter of older people are socially isolated. So based on what we're seeing, you know, we're right in line with that. So to me, that's showing me that the real world application of this instrument is very successful so far. So I'm really pleased with the performance in the real world, as opposed to our, you know, academic labs and things like that. So the actual setup of the instrument is 6 items. And when I've timed folks, which I always do, you know, on average, just to answer the 6 questions, it takes people on average less than 3 minutes to complete it. Some more, some less, of course. And it can be completed in any number of modes of administration. So you can print it out in paper, you could send a computer link by SurveyMonkey or Microsoft Forms or any of the other survey data software programs. It can be self-administered, it can be read by somebody over the phone. It's really versatile, and that is something I think is a real strength. The top section, which is the objective part, has 3 questions. And those 3 questions have responses that are the same for all 3. And those responses are none on one side for the anchor, and then 6 or more on the other side of the anchor. So it goes from none to 1, then 2 to 3, then 4 to 5, and then 6 or more. So that is the responses for the first 3, the objective connectedness side. And then the responses for the subjective side are strongly disagree, somewhat disagree, neither agree nor disagree, somewhat agree, and then strongly agree. So we wanted to have a mixture of the Likert type scales for objective and subjective aspect of the instrument. So we put all of those things in, and people are really able to understand the instrument, how to answer it. And we get a summary score, and based on that summary score, we can put them into the quartiles, and we can have a really good sense as to whether or not they are isolated, high risk, low risk, or probably not at risk at all. So at this point, I would like to say next slide. So thank you.
So as Professor Nicholson indicated, we ended up using those 6 questions in our SurveyMonkey online tool, but we also wanted to add questions that would help to provide a much more holistic view of the person in preparation for any consultation that we might be sending an individual to, and to also obtain some of that information of what might be important to or for an individual to be person-centered in that consultation with the individual. So we asked such questions as whether or not they've been able to be connected with their religious community, or if that was not or important to them, and whether they've been able to get items they need, such as groceries, money, and medication. And then we also included questions that would purposely help to eliminate extra reporting for the area agencies on aging and centers for independent living, that included information about their demographics of their age, whether they lived by themselves, similar to some of the questions that Professor Nicholson mentioned didn't associate for the isolation scale, but would be important in looking at who is answering these and who we were touching. And many of those questions really paralleled the older Americans Act reporting form that many of the area agencies on aging are familiar with. Next slide.
So as you heard about the social isolation scale, we were able to identify a cutoff. So based on the responses to those 6 questions, and in our case, we're primarily administering the survey via phone call. I had the pleasure of doing one myself, and it actually took a little longer because there's some dialogue going back and forth in going through the questions and walking the person through it. But overall, as we go through all the questions in the SurveyMonkey, once you submit it, you do get that final score to determine if the person meets the criteria for social isolation. If so, then the point person at the Area Agency on Aging or the Center for Independent Living sends that brief referral form over to the AT partner that's been assigned to them. Well, Connecticut is a fairly small state, and we have 3 AT partners, so we essentially divided the state into 3, and based on where the individual lives, the AT partners will cover those specific towns. Because we're doing these AT consultations remotely, it didn't matter if the person lived very far away or very near to the AT partner. Also, it's important to note that we're calling these consultations as they are not as in-depth as a full comprehensive assistive technology evaluation. We're really focusing on what is the best technology match for the individual for them to be able to engage and connect with their family, with their friends, their community, or to participate in telehealth. If appropriate, a remote AT demonstration could be conducted by the AT partner. And we also have built in the opportunity to send a device out for short-term loan to let the person try the device at their home and see if it's going to work for them the way we expect it's going to work. Are they going to use it? That kind of thing. And then we can make that appropriate recommendation based on that AT device loan. Once done, the AT partner will do a brief report with recommendations in writing and send that to Patty and I, as Patty mentioned, and we'll also send it to the point person who made the initial referral. We thought it was important and helpful if we're looking for external funding sources to have written justification at the ready so we can go ahead and submit for that. For example, Patty mentioned the Connecticut Charitable Trust Foundation that we have here in Connecticut. they meet monthly, making their decisions about awarding grants. And so if they're going to meet, next week, we want to have that information ready so the application can be submitted. Our goal is to maximize our funds as much as possible. So if there is any other funding source that's able to pay for the recommended device, we absolutely want to try to tap into that funding source. And then this way, we can use the funding that we have to focus on the upfront AT consultation and the back end training with the person to make sure that they can maximize their use. Devices can be sent directly to the individual if that's appropriate, or directly to the AT consultant, who might then take the time to set it up, download the appropriate apps, and have it ready for the person before getting it to them. And then once it's received, as we said, the partner agency will provide the appropriate training to ensure that the individual and their family or caregiver, if that's appropriate, know how to use it best. We also developed some forms around online safety, as well as who to contact if the person is having trouble using the device, or if they don't want it or are not using it at all and want to donate it back to us. We're more than happy to reutilize it and get it out to somebody else who could use it. It was really important for Patty and I to make sure that this process is full circle, that we didn't spend all of our time on the upfront AT consultation only, and that we made sure that we were able to close the loop with each person and provide the consultation, the equipment, and the training. So that loop is very important to us. Next slide, please. If the individual is screened and is determined not to be eligible for the Stay Connected program and the AT consultation based on the results of the social isolation scale, then the Area Agency on Aging or Center for Independent Living can provide other resources and information that might be available to them, including connecting them to their community-based services and screening them for any other programs that they may be eligible for. And one of the other programs might be Professor Nicholson's Zero Isolation Program. So I'll let him explain that to you as well. Professor?
Yeah, great, Arlene, thanks. Yeah, I appreciate the opportunity to talk just a little bit about this program that I'm sort of working on here. And the program is called Zero Isolation, Building Socially Integrated Communities. And the program itself was developed to address social isolation and loneliness and a few other things through a short series of in-person, virtual now, as well as telephonic meetings. So the design of the program, I think, is pretty simple. It's been found to be effective, and it's evidence-based. The methodologies are there, and it's used to improve social integration. So every session follows a conceptual framework that operationalizes the state of the science methods for promoting engagement, building cohesion, bonding among the members of the group, and all in a safe and supportive environment. So the group members are provided knowledge about pertinent social conditions, so we teach them, and we help them with necessary social skills for engaging or re-engaging in their own outside community. So the group members hone their skills through practice activities that use a variety of methods, including role modeling, coaching, small group work. In order to internalize the lessons, we have a number of activities that the group members participate in outside of the actual group meetings. So the group members are asked to journal. So that's specifically done with prompts, and to complete these activities are intended to help practice the skills and build confidence and engage socially, and hopefully have success, and they can share that with the group. And if they don't have success, they're also able to share that with the group, so the group can learn and help each other kind of move forward. Group members are paired with what I call a group navigator, who contacts them regularly throughout the program. And those connection points serve to ensure that not only do the people show up to the first session, but that they develop a mentored relationship throughout. Not only with the facilitator, but also with a second person. And that second person, the group navigator, tends to be, you know, just for sake of necessity, some of my college students and students from the area, volunteers. And those people tend to be younger. So then there's a really nice intergenerational aspect to the program going on as well. So that's something I think that we're really proud of, and it's been really, really helpful. And it's been an opportunity for not only the older people to connect, but for the younger people to connect and learn as well. The structure of the program itself is it's 6 weeks, and each week the participants take part in a 90-minute session. Each group has 8 participants and also 1 or 2 navigators who you know, are part of the group, and also a co-facilitator. So anywhere between 1 or 2 facilitators, depending on the group. And the Zero Isolation program has a comprehensive evaluative component. As you can imagine, we use the social isolation scale, but there's also other measures as well, because we are measuring other constructs too. So we have 3 modes of administration with 1 program. We've got on ground, which is where we started. When we all were working through COVID-19, we pivoted to online, and now we're moving into the telephone aspect of this as well. And all of this is in, right now we're working in collaboration with AARP Connecticut and Rhode Island. So we're test piloting the program over the next 3 months, you know, training service providers and students in Connecticut and Rhode Island as part of an effort to continue evaluating its effectiveness in reducing isolation and of the training process itself. So at the close of the pilot, we're going to be working to officially launch the training. And the nice thing is this pilot's being supported by AARP Connecticut and Rhode Island, who have helped identify universities, professionals in both states who are interested in taking part of this. And AARP also provided a nice opportunity for me to share this project through a story that they put together. And I was interviewed for back in January of this year in the Bulletin. So we got a lot of interest in this program, and we're hoping to continue to build on that interest and really at the end of the day help older adults who may be isolated. So.
So I couldn't help it. I took a peek at the questions, and I see some really good questions coming in. But one of them in particular prompted me, before I talk about this slide, I just wanted to mention that part of the contract that we initiated with the AT partners, we included a line item for PPE, specifically because this is related to COVID. And so each AT partner was able to obtain the necessary PPE equipment that they needed. And then I also was able, through the AT funds, able to purchase several home soaps, which is made from the company of Phone Soap. And it's basically a UV light box that is the size, large enough to fit in like a laptop and other pieces of equipment. So if devices are sent directly to the AT partner, they are able to be sanitized before being sent out to the individual. And then the other thing I wanted to mention, which I forgot to say earlier, is that we have encountered individuals who have technology and they just don't know how to use it. So maybe they have an iPad, maybe they already have a computer, but they're not able to socially connect because they don't have the understanding of how to use the device. And in those cases, we are also referring them to our AT partners for training. This is one of the few programs where we can actually use the funding to pay for the training to really ensure that the person utilizes the device. So now I'll talk about this slide, which is one of the things we're very excited about in this program is that we actually intend to follow the person through the life of the grant. We're not just providing them with a consultation and a device and then walking away. We're able to determine if they're eligible, provide them the services, and then 30 days after their training is complete, the AT partner is going to be conducting a post-survey with the individual. This post-survey includes the same 6 questions from the social isolation scale, as well as some of the other questions that are on our SurveyMonkey list of questions. And then we added a few additional questions related to their use of the technology that they received. Professor Nicholson is being very generous with his research students and allowing them to continue to provide that same post-survey to the individuals we serve 60 days after the training, and then quarterly thereafter through the end of the grant. And so this is going to provide him with longitudinal data that will allow him to adjust and improve his scale, hopefully validate it for persons with disabilities, and then also provide us with long-term data on social isolation and the use of technology. And also, it gives the individuals the opportunity to know that they're going to be having someone follow up with them on a regular and consistent basis. They can ask for additional support if they need it, and hopefully reduce abandonment of the device, and allow us to be responsive. If they have a device that they're not using or is not working for them, then we want to try to find something else that will work for them and swap it out if we can. So it allows us to then take the device back, get that to someone else, give them something new, and ensure that they are able to get connected. Next slide, please. So we were able to get the contracts in place. We ironed out the process and procedures, with some feedback going back and forth. We developed a screening tool and launched the program on June 29th of this year. As of this past Monday, we've screened 265 individuals. That's through the help of our area agencies on aging, Centers for Independent Living, which we're very grateful for. 79 of those individuals were referred for AT consultations. A few of the individuals were eligible but did not want to pursue technology. And then as of Monday, 32 of those individuals that were referred have received their AT consultations. And then from there, some of them have already received their technology, and some have already received training, and others are somewhere in between in that process. Patty and I actually had to put our referrals on hold. As I mentioned earlier, it's really important to us that we close the loop and make sure that we have people receive the AT consultation, obtain the equipment, and receive the training. And so we didn't want to run out of money and provide 265 consultations and then not be able to train them on the use of the devices that they receive, or maybe not even get the device. So we've put the referrals on hold. The area agencies on aging and Centers for Independent Living are still screening, and they're still completing the AT remote consultation form for anybody who is eligible. And those are coming to Patty and I, and we've started a waiting list essentially. Once the AT partners are able to kind of get through the individuals that they've already received referrals on and can close the loop and make sure that those are set to go, then Patty and I can go ahead and resume opening the referrals and get them back out to everyone. And each AT partner is a little different. One of them got a lot of referrals up front. And so we were able to be responsive and make some changes and ask that a few referrals get sent over to somebody else so that we could balance it out and have the capacity to serve all the individuals. And I think we've tried to be as fluid and responsive as possible. We've tried to be open to feedback. We meet with our partners, all of the partners, on a monthly basis to hear from them and to tweak our process and hopefully improve the process. When we started, I don't think that we thought we would put this on hold so quickly. Our goal when we wrote the contracts with the AT partners was that we would serve a minimum of 60 individuals or more, and we are in the or more already, which is exciting. So hopefully we will be able to open up and start accepting more of those AT consultations and serve even more individuals. Next slide, please. And so, actually, this is Patty's slide.
So what's next? As we were envisioning the project, they were, we started first with the initial phases of it, but we had always, based on the survey results, we're very aware that the senior centers and libraries had been offering very valuable computer training and support to individuals prior to the pandemic, and often on a volunteer basis. But what we received when we surveyed these as both the libraries and senior centers, was that primarily most of that work had been stopped during the pandemic. So what our goal really is now that we've been having some time and knowing what type of devices were best suited for many of the individuals, and we have some more data about how do you train individuals on the various devices, of narrowing that down, of working and sharing that information with the libraries and senior centers with the hope of resurrecting that volunteer base so that we can have a place to refer individuals to if they don't meet our criteria, or following the training if down the line they're needing assistance because they have a stumbling block with the use of the technology or want to use something new with it and don't know how to do that, that we can seamlessly connect individuals to their own community with all the resources that they have. We also met with a nonprofit agency in our state called UR Community Cares, and their really a goal is to match individuals who are volunteering, who want to provide a service, to individuals who are seeking a service. So that to us, that was a natural way of helping individuals that are getting who would be able to provide that technology support and matching that with individuals. So our next step is, and they're very interested, we've talked with them, of partnering with them and working towards that goal of really making that a little bit more streamlined as people are finishing the training portion of their technology experience through the Stay Connected program. We are also working with our state lead in the National Family Caregiver Support Program to see how they can continue to offer technology training and possibly training and support for individuals who are either caregivers or persons who are receiving supports through the caregiver program, so that they can continue to get the benefits of technology following our grant, or in the absence of them not qualifying for our particular grant. We also hope that the data that we're collecting and the challenges we're learning will help to provide information for some policy decisions moving forward. At some our initial challenges that we have identified is we are aware of the concern of sustainability for internet following the grant. We do have pockets in our state that have unreliable internet access, and hotspot reliability is a challenge. And incorporating, hopefully, with maybe the data demonstrating the value of training and support, of maybe having some policy decisions around Medicaid-funded support for individuals, and ensuring that the technology that is getting in their hands is actually the best suited for what their needs are, and that they're using it appropriately. And also, we became aware earlier on that there was a CMS directive to Medicare Advantage plans that equipment provided for telehealth services for medical purposes had to be locked up when it's in the home and could not be used for other social determinants that we know is important. So we're hoping that down the line that gets remedied, and that if devices are in the home, that those devices could be used for more than just telehealth services. And I believe the next slide.
All right, so, we can talk about this. I know we've shared a lot of information, and hopefully it's been informative, but sharing stories is the best way to drive it home. So we have just a few anecdotes to share with you. This is an anecdote about a consumer who is a primary caregiver for her husband. She essentially limited her time away from home due to the concern of her husband's well-being and not wanting to be away from him. So she loved the idea of using a drop-in feature with video to check in on him, even if she's in just the other room, or if she's out running errands or meeting with a friend for a quick lunch. So the AT partner recommended the Amazon Echo Show, which is set up and the individual uses it where family and friends can send photos so that he can see a slideshow, and is able to see that directly, and is also able to have the wife, who's the caregiver, call in and drop in on him, and she's able to see him and communicate with him verbally. So even if she's next door or in another room or out of the house, she's able to see how he's doing. And then he's also able to call for help using the voice activated feature to make phone calls to other individuals or for emergency services. This device was funded through the National Family Caregiver Program, And then our CARES Act funding paid for the consultation and for any training that was needed. Next slide, please. We had another consumer who was using her daughter's smartphone to attend church service through Zoom. So, of course, the daughter could not use her phone while the mom was using it for a church. But the mom, who had low vision, was hoping to have a device that had a larger screen. And she wanted to be able to also connect with family and friends and use FaceTime, as well as Zoom, as well as use it for telehealth. In this case, iPad's 10.2 inch was recommended, and this was funded through the CARES Act funding, along with the consultation and the training. Next slide, please. And the last anecdote I want to share, we had a consumer who had limited mobility due to a brain injury, and she was requesting technology to help her connect with her family and friends by phone calls or by video chats, but that had a large enough screen for her to be able to see well. In this case, an iPhone 11 Pro Max was recommended, and it was funded through a grant from our partner agency, UCP of Eastern Connecticut. We did hear back from this individual, and she loves being able to attend church. She uses it to check in with family and friends using Zoom. She listens to music and to books. She is attending events through her senior center, like choir practice, and has said that this has been an amazing opportunity for her. So for us, you know, as Professor Nicholson said earlier, the real world impact is so important and meaningful. And hearing these stories, and these are just three, I mean, you saw the numbers, we've had a lot of referrals and we've had a lot of successes already. In addition to encountering some of the barriers that Patty mentioned, but we're really excited to see the positive impact that this is having on the residents of our state. Next slide. Yes, and now it's time for questions and answers. And as I said, I did peek and I saw some really good questions, so I'm looking forward to going over those.
Thanks, Arlene. You're right. There are a number of questions, both in the chat and the Q&A. So let's start with the questions and answers and see if we can get through those. There are 11 questions. First question was, sorry if I missed it, for the social isolation scale question about seeing people face-to-face once a month. Does that include via video conference or FaceTime, or only in person?
So the social isolation scale, that first question, the face-to-face, is intended to measure only folks who are actually in front of them, sort of more or less an on-ground experience. So Skype, Zoom, the other video chatting features, I would count that under the second question.
Okay, the next question was, are the slides going to be available for downloading, and we may attend a copy of the transcript? This is from a deaf user.
And this is Kim. I can take that question. Yes, the PowerPoint and materials will be posted on AT3's website in approximately 1 week. We will also be posting the recording online, and there will be, it will be captioned. And in addition, tomorrow you will be receiving the link to the survey. Attached to that email will be 3 documents that Professor Nicholson has provided regarding the social isolation scale, and also more information about the zero isolation training.
Thank you, Kim. The next question is, are you providing hotspots or MiFis if needed to participate in virtual AT consult or demo?
So, as I said earlier, we're trying to be as fluid and responsive as possible. One of the other line items I had was a line item for myself to purchase inventory items so that we could lend out items to individuals when the AT Partners item was not available. So let's say they did a loan of an iPad and they needed another iPad, I could order it and send it over to them. What we quickly found out is that we do have some people who do not have internet and do not have access to a Wi-Fi at all, even low-cost Wi-Fi. And so instead of purchasing backup inventory items, I have recently just purchased several hotspots, which we're going to try to implement and get out to people as needed, as a last resort. Unfortunately, we don't, it's not a large supply, but we'll see what we can do with that. In terms of the AT consults, if the person does not have internet, those have been done just by telephone to start, or with the help of a family member or friend who's there who's able to assist. For example, the one with the daughter who had the iPhone, we could just ask the daughter to connect via Zoom using her technology.
Thanks, Arlene. The next question is, was there any consideration given to the elderly person who tried the technology, such as FaceTime, only to feel more isolated as they could not have the touch that they crave from family members and friends? I have had the experience of the elderly being more depressed after using the technology.
Wow, that's a great point. We haven't experienced that yet. We're still on the front end of this in terms of getting the technology out and providing the training. We're going to do that post-survey 30 days after the training, and I think that's the window where we're really going to find out if their social isolation scores go down and they are even more isolated, or they express more concerns, because there are some open-ended questions there that they can tell us how they're feeling, how they're doing. That's definitely something we would want to discuss and see how else we can address. But as of this moment, that hasn't happened yet, but I appreciate hearing that and knowing that it's something that could come up, so we can plan for that.
The next question is, would it be possible to share the actual contracts the program has with Centers for Independent Living, Voc Rehab, etc.? I am interested in the language that designate who is doing what.
I'm happy to share the contracts that I've created. And Patty, I don't know if you want to speak to the ones that you've created and if you're comfortable doing that.
All of our contracts are available for public review, so I have no problems with sharing any of the language, if that's helpful.
Scott, I would just say that our emails are at the end of this presentation, and you're welcome to reach out to us, and we can get that to you.
Thanks, Arlene.
I did want to say one comment that I think once the screening process is over, the feedback we had from the Centers for Independent Living and the Area Agency on Aging is that, asking questions that really help to frame what an individual might need does take a little bit of time, and it's a little bit longer than what are potentially an information referral typical call might be. So that has been something that I think the length of time is a little longer than I think we anticipated initially. But it has been, part of what we're trying to do is to gather as much information. Some of those Centers for Independent Living have relationships already with some of the individuals they're working with. And so they have content information that is even beyond what we had for survey. So we did encourage them to share information that they knew would be important for the individual or important to the individual, so that when the consultation takes place, they're knowing, kind of factoring that in when they're meeting with the individual. And someone had a question that I saw in the chat that I wanted to respond to, and I'm trying to remember what it was.
I think Dave is going to read those.
Yes, okay.
Yeah, as soon as we get through with the Q&A, we'll move into the chat.
Okay.
So Christina Amadeo asked, thank you so much for the great training. Would you let us know who your contacting is in Rhode Island? And perhaps that can be a communication following this by email with Arlene.
Yeah, absolutely.
Okay.
Yeah, absolutely. Share that. I'm happy to, and I can certainly, once our email is up on the screen, if you email me, I'd be happy to provide that, or anyone else who might have an interest in the contact in Rhode Island.
Thank you, Professor.
Thank you.
Angela is asking, will the presenters be sharing the assessment tools? The ADRCs in Texas are just now contacting the TTAP with CARES funding to spend.
I think that's a question more for Professor Nicholson first. any of the questions that we've added to his scale, we would be happy to share.
Yeah, I
Professor,
mean,
do you want to go talk about that one?
sure. Yeah, I mean, as far as the tools go, so I would say that what we're using in this project, I think, is predominantly instruments. I know there's some, what's a tool, what's an index, and all that. So I think basically that what we're using are they're strong measures of the concepts, and I would be happy to share the social isolation scale. And in consultation with Patty and Arlene, I would, we could certainly provide whatever we have as far as what measures and how we're measuring it and why we're measuring it that way. I mean, one example might be something like if you were measuring a different construct, such as loneliness, for example, depending on your specific population, there are different instruments that you may want to consider because there's multiple instruments that measure loneliness, and the way that they're the way that they're structured may be better or worse for your, specific population. So I think for me, I would be happy to share what we're using.
Thank you. The next question is, how will you proceed if they cannot either access or afford Wi-Fi?
So we are trying to tap into funding from any source that we can possibly find it, including to pay for Wi-Fi or hotspots, over the course of the grant. Some of the devices that we are providing, such as the Birdsong, which is a tablet that's geared towards older adults, we've been able to negotiate and work with them, and they've created the tablet with built-in cellular, and we've been able to negotiate a government rate for that. So if that device is recommended and it's paid for, whether it's through our funding or a different funding source, the person will have 1 year of service to utilize the device. Thereafter is a big question mark, and that's where Patty talked earlier about sustainability and working with other partner agencies and community partners to see if we can find a way to help sustain that. So we're still looking for answers there. We're open to hearing if anybody has good working partnerships and suggestions for us. And Patty, I don't know if you want to add to that.
I would just say that we're aware of many of the lower income internet opportunities, but what we have found is the reality is that there are, and of course some of those lower income internet access are dependent on where geographically where you are, but in many respects it is not as low income as one would expect. So I think it still remains a challenge. I'm not sure that that challenge is as that awareness of those challenges are as noted as, because everything I ever see, it gives the impression that if somebody's low income, they can access internet at a very low price. And what I have found is that actually is not the case. There are some things, not all of them participate, some of them are limited. So I think that is going to be something of work, I think, on at least on our statewide level, that, and I'm assuming probably on a national level, are probably going to be issues that will surface of infrastructure needs and how to best serve that, because that's not unique to our population of older adults and persons with disability, but it applies to children and other people who are lower income, not with disabilities, who have challenges in accessing the internet. So I think those are probably going to surface, I think, as time goes on. So I think they're not, unfortunately, not unique, but and I did want to comment about the survey that we're doing. So I did want to, the question about the assessments, what the area agencies on aging and centers for independent living are doing are not full assessments. It's embedded within the information referral, and they're gathering information that's helpful for the consultation. It might be that it might result in an assessment for an aging and disability resource center, but I'd say the vast majority are not necessarily that what they're screening for are other programs like the National Family Caregiver Program, seeing if they're eligible for maybe a Medicaid waiver program that they can connect them to, but it may not necessarily, they're not using a full assessment in this particular project. But I'd be happy to share this survey of the additional questions that we're asking with anybody who's interested.
Thank you. The next question is for Professor Nicholson. For your follow-up, are you including a measurement of depression, such as CES-D, to understand covarieties? This is from Victoria Panzer.
So as far as the research that I conduct, just in general, I think it's I think measuring depression is really important, because depression is something that often confounds social isolation and some of these other socials that are part of you know, this literature. So the CESD and the GDS are ones that I often use. In this case, I think I'm going to punt to Patty and or Arlene to talk specifically about the depression aspect of the measurement in this project, though.
The survey does not have a tool that is measuring that depression. But if that was surfacing through the conversation, we do have referral sources to connect. We have a senior outreach and engagement staff that are specifically in our state designed to engage individuals that have behavioral health issues with getting them into treatment and getting connected with that. And then for individuals that have a disability below the age of 55 that would not meet that criteria, there would be other resources that we would connect them to. But the survey itself does not include it. You know, our intent was to embed it within the existing core services that we're offering services to older adults and persons with disabilities already. And then we also, and I know this was a question, we did share with professionals that we were doing this project and explained that if they felt someone might meet the criteria, that they could have them contact the Area Agency on Aging or Center for Independent Living and ask to be screened for the Stay Connected program. But we did not specifically provide public information about the project to individuals, because we were concerned that people would be contacting us specifically to get technology and not necessarily that we would not be able to serve everyone. So we were trying to be, we felt we had enough people that we were meeting by just screening individuals that were coming into the Centers for Independent Living or Area Agencies on Aging, which they do multiple programs in our state. So that captures people, you know, new to Medicare or other types of things. So it's not just people. So we felt we were capturing quite a number of people. And as you can tell, we're already maximizing the number we can serve. So I think we've achieved what we were aiming to do.
Great. The next question is, what type of devices were best suited for most of your program participants?
So every report that comes in, I do review eagerly, and I'm often very excited by what I'm seeing to see that we are able to make a good match for the person that's going to really positively impact their life. Some of the things that we've seen, and there hasn't really been like one trending item, but it's definitely been iPad, Samsung tablets, the Birdsong has been recommended several times, the Amazon Alexa, and then most recently, some very low-cost laptops for those individuals who have experience with computing and are maybe not comfortable with the tablet, but cost-wise, they're comparable. So it's been all of those things.
Thank you. And the next question is, when you say an iPad was purchased with CARES Act funding, who is actually in charge of that device acquisition? For example, can you, as a state AT Act program, purchase a consumer device, or was that facilitated by another organization?
So part of the contracts with the AT partners, another line item was funding specific for consumer inventory items. So it is possible that the AT partner, after doing the consultation and consulting back with the initial referring agency, if there is no other funding source, that partner may use CARES Act funding from the grant through their contract to purchase that equipment specifically for the individual. It all has to be accounted for and tracked. It's also possible, because CARES Act funding went to the Centers for Independent Living, that they might use their CARES Act funding to purchase equipment for the individual. So it could be either one.
Thank you. And finally, in this a clarifying question. Are you able to provide 1 year of service, or is it service until the end of the CARES Act funding?
Well, because we're early in the grant program, we've only done this a few times so far where it has been 1 year of funding. It also depends on who's funding the service. If it's the National Family Caregivers Program or a different funding source, then we're asking for a full year. If it's the Connecticut Charitable Trust. As one of the things that we've calculated into the budget, even with the hotspots, is that as we move into the months, that timetable decreases. So we may have budgeted for a full year, but we'll only be providing, say, 6 months worth if that's the amount of time that's remaining on the grant period. So hopefully that helps to clarify and answer that question.
Thanks, Arlene. So now I'm going to jump into the chat section. Somebody early in the chat asked for the definition of social distancing to be listed in the chat. Perhaps that was Wendy. She might be able to reach out to Professor Nicholson and get the exact definition, or it will be included in the documents that will be sent out tomorrow along with the survey. And the next question was about getting a copy of the PowerPoint, which has already been answered. And somebody was having trouble with the audio and the PowerPoint slides. Yep, we're on the right slide. Most of these are process questions. Please post the panelists' contact information, which will be at the end. How was sanitization of loaned equipment handled in light of COVID? Arlene, you answered some of that with the phone soap question. Would you want to elaborate on that?
Our partner agencies were able to obtain UV light wands for those who wanted it and were comfortable using it. The home soap, which I provided, through a different grant that we oversee, we were able to provide additional UV light boxes to some of the partner agencies. And then, as we said, there's a line item for them to purchase PPE, and so wipes and other, gloves and other protective equipment could be purchased directly by the AT partner, so they could utilize it to sanitize any device that they have to then bring out to another person. And I will say also that although this has been primarily a remote service delivery, we did have one partner agency, maybe more than one, but one that I'm sure of, who actually took a road trip and delivered 4, or maybe it was even 5 devices on one day to a variety of individuals, just by essentially letting them know that she was going to be there, dropping it off on their front step, and then walking away, and then just ensuring that the person obtained the device. And then the training thereafter was provided remotely. So for the most part, it is remote services, but in that situation, it was hand delivered.
Thank you. Another question in the chat is, was a device called the GrandPad used in your program?
Yeah, we worked with Consumer Cellular and have a relationship with them. They have given us 3 demo units, 1 for each partner agency. Actually, even before we started and actually launched the program, one of the AT partners was able to use their a separate grant funding to purchase the GrandPad for a couple of people. I think I would say, for the individuals that it was provided to, it has been successful. We also, as we've said several times, are trying to maximize funds. And so in comparison, the monthly payments might be a little bit on the higher side for that device versus another. So that comparison is also being done. But it is in the inventory kit, so to speak, and is being considered as appropriate for the individual based on their needs.
Thank you. Another question from Aaron Emery. We're also providing tablets and training for older adults. Would love to connect about the curriculum your coaches use. So hopefully the two of you can connect afterwards.
Please.
Another question. Did you actively seek out and identify isolated individuals, or were participants acquired via the intake process for other services?
So this, I think I mentioned, referenced this. So we did not specifically send information out to individuals. What we did is reached out to professionals that we knew potentially were working with that population. So as we mentioned, when we met with all the Medicaid programs that work with individuals who are receiving long-term care services and supports, with respite care managers that often are the first step to assisting people seeking long-term care services and supports, to the mental health agencies that the senior outreach and engagement staff that I mentioned that are working with individuals that might be isolated. So what we did is sent out to professionals and people working like resident service coordinators, and we had meetings with senior centers, let them know what we were doing, what the project was, so that if they identified someone, they would refer rather than sending it out to the specific individual, because we felt that they would be better able to identify those that were really at risk.
And I would add that being the assistive technology consultant for VR, any VR consumer who needs AT essentially comes through me anyway, at least for discussion, so I could gear them to this program if appropriate. Or vice versa, if the person should be getting something from VR, I could help with that. And then I also did an e-blast on my newsletter, which goes out to about 500 individuals, just to share the news of what we were doing. And I think that might have also assisted with some of the referrals.
Thanks, Arlene. So we have an individual from Arkansas, New York, and San Francisco, all hoping to connect post-webinar and have conversation and connection. Right. So hopefully everybody will reach out. Sorry. Do you have a percentage breakdown of seniors versus people with disabilities?
That's a good one. Patty, do you want to talk about that one?
We probably do have that. We didn't prepare that. That probably should have been something we would have anticipated. I think Arlene and I both work with both populations, so we tend not to think in separation, but we do, because we have collected the demographics, we can easily collect that information from our Survey Monkey of how many were screened. And I think that we would have to look a little bit more carefully of those that were screened and referred, how many by age or disability. We did ask in the Survey Monkey, we were asked like the nature of the potential disability, and part of that was mainly for information of if there was a Medicaid program that might be able to fund technology, not to be invasive. So for instance, our Department of Developmental Disabilities Medicaid waiver does pay for not only internet, but also technology. They're one of the few. But if we were able to determine what type of disability or program they might be on, we would be able to identify the most appropriate funding source. Most of the 10 agencies, 8 of them have read-only access to our Medicaid database system, so they have the ability to go in if somebody's identifying that they have Medicaid to find out if they are on Medicaid and whether it's a Medicaid waiver program, so that we could more effectively reach out to that particular program to see about working together to get the technology funded. So because they're ADRC, they have access to some information that would not normally be available to them.
Thank you. There was a question about partnerships, whether or not you had a previous arrangements and in place, or is this a new partnership? Can you speak to that a little bit, Arlene?
Well, Patty and I both work for the Department of Aging and Disability Services and have had several conversations working together for No Wrong Door, and also just with veterans. I've had the pleasure of presenting to one of her groups, and so we've communicated many times in the past, and have kind of laid some groundwork to partner. But this is the first time we're really partnering together. So in depth and successfully, in my opinion. And then she was the one who was able to connect with Professor Nicholson to engage him into this project.
Great, and I'm just going to interject here. This is Kim again. We have about 5 more minutes, so we can take questions for another 5 minutes, and then afterwards, once again, we will be posting this information, but the contact information is up on the screen right now. we could just continue the conversation and maybe have another webinar when you're further down the road and have more information to share. Dave, I'll let you take it away again.
Thanks, Kim. Washington State has been impacted by COVID. Large numbers of people have contracted the virus and are further isolated by quarantine. Wondering if this is the same in all states, and I'd love to see a template or contract language as well. So hopefully Wendy from Washington will reach out to one of you. The level of networking on this project is awesome. Well done. Victoria Branzer sent a Q&A technical research question about depression scale. Please make sure Nick sees it. Let's see. Sorry. How are seniors trained on these devices? Would you talk more about the training process? Thank you.
So when the individual obtains the device from whatever funding source is used, the AT partner agency, the point person, is notified if they're not the one who's actually purchasing it for the individual. And so then they would do the follow-up with that person to provide training. And it's going to be based on the individual's knowledge and skills, if they already have some tech savviness or not. It may start off with a phone call, it may move into video chat, but it's all done completely individualized. We haven't put a cap on the number of hours. You know, again, we're still in the early part of this, so we're still assessing some of that data. And actually, Patty and I next week will be looking at how much time has been spent on consultations versus training. So training is just basically provided remotely on a one-to-one basis. And if the person has a family member or caregiver, they're welcome to join the training so they can learn and then, you know, help support the individual.
Thanks, Arlene. And I think this is going to be the last question we have time for. But the question is, how is support for the different devices provided? I think that may be a question that's different than training, maybe technical support for the device itself.
So again, you know, we are really doing an individual basis in terms of the consultation, the recommendation for the device, and the training. Some of the devices provided, like the birdsong, comes with training from the manufacturer. So in those cases, we're going to defer to them, and they also provide ongoing technical support. Some of the devices, like an Apple iPad, it's possible they may be able to get videos or support from the Apple Store when possible. COVID has been big here as well. I'm very proud of our state that we've really gotten the numbers to a manageable point, but we are all still working remotely primarily. And then also the AT consultant is available, you know, for follow-up, and we're giving the document to the individual who receives a device that tells them how to reach out to us if they need additional support. And then, as Patty mentioned, we're trying to tap community resources that could provide ongoing tech support through volunteers and mentors and that kind of thing.
Thank you to all the participants. I think at this point, we're going to culminate the questions and answers, and I'm going to turn it back over to Kim to wrap up the webinar.
Great. Thank you, Dave. So on behalf of AT3, I want to give a big thanks to Professor Nicholson, Patty Richardson, and Arlene Lugo for sharing their time and expertise today and letting us know more about the Stay Connected program. And a big thank you to all of you for joining today. Please be sure to check your inbox tomorrow for more information and the survey link. And everybody have a wonderful afternoon, and we'll see you next time. Goodbye, everyone.
Thanks so much, everyone. Thank you.